Morning, everybody, and welcome to Grand Rounds. As mentioned, next week our speaker will be Wendy Chung, who's a Columbia faculty member in pediatrics and genetics, who will be speaking on genetics insights into autism and related neurodevelopmental conditions. A couple of announcements. One is that Renee Henn received a NOGA from the NIMH for an R01 on cellular mechanisms of antidepressant action, which is always good to have or good to hear. Also, you know, we don't necessarily pay much attention to these beauty contests of ratings, you know, like U.S. News and World Report and Doximity, but it's better to be mentioned than not mentioned. So I was just informed that in terms of our residency program, which is timely since we're in applicant season, we were ranked this year #1. And my recollection, well, this is not news. We knew this all the time, but it just means that the rest of the country knows this or acknowledges it anyway. So that's positive affirmation. And congratulations to all the people that have anything to do with it, particularly the training directors and the residents and the chiefs. And we have some applicants here today. So in the discussion that follows the presentation, feel free to ask questions or make comments or everything. It's a very friendly audience. Nobody's going to laugh or, bite your head off or anything. So today we have one of our own faculty, Bret Rutherford, to give grand rounds. And it's always good to have our faculty presenting to everybody because the department is large and diverse, and not surprisingly, it's hard to keep track of what everybody is doing, so it's a great opportunity to see that. But Bret represents what I see as one of the unique aspects and real strengths of Columbia and NISP, which is that we grow our own. And that's good as opposed to becoming inbred because we have people that have trained here, we know them, we've sort of inculcated the right values and put them hopefully on very successful career paths, and having them present and see what they've achieved, is a way of demonstrating and for reaffirming that. So Bret hails from the Midwest, born in Joliet, Illinois, and then came east for college where he was an undergraduate at Harvard, then came to New York where he received his medical degree. He then did an internship in medicine and then residency in psychiatry, and then a research fellowship in anxiety and depression. Along the way, he distinguished himself in a number of ways. He was AOA, he was chief resident, and he received the Samuel Perry Award, which is an award that's given to Columbia Cornell residents for their specific research. Bret has sort of risen academically to his current rank of associate professor, and also he directs the newly formed division on brain aging and mental health along with Dev Devanand. And Bret's work has focused on mood anxiety, but in older people. We're trying to come up with the right kind of euphemism as opposed to senescent, late life, geriatric. The term that I heard most recently was millennials, or not, no, perennials. I guess I'm becoming a perennial. And did, a series of studies really under the tutelage of Steve Roos on study design and methodology, particularly in terms of placebo effects. And placebo is an issue that's been of interest historically, but particularly timely and also complicated now because there's been this rising placebo response rate with psychotropic drugs, which have really bedeviled the process of developing treatments and confounded the field, the FDA, and I think played a big role in driving a lot of companies out of the psychotropic drug development business. But I think Bret's series of papers, which is about maybe around 10 or so, one of the most rigorous sort of assessments of placebo effects and the contributing factors, to that. But subsequently, his work moved on to really studying more of the kind of biology and the factors that go into healthy brain aging in late life and what factors contribute to psychopathology. And between him, Dev Devnan, Steve Roos, Patrick Brown, probably forgetting a couple of other people, formed a nidus to try and focus on the maturational process of the brain as it moves beyond middle age in terms of how to sustain itself optimally and in terms of what factors may contribute to some pathologic compromise, whether it takes the form of depression, dementia, PTSD, or otherwise. In this context, Bret's work has been consistently funded. Currently, he has 2 R01s, one in the area with Patrick Brown on neurocognitive and neuroimaging biomarkers, which predict progression towards dementia in patients with treatment-resistant depression, and another in conjunction with Yuval Nuria on cognitive and neural mechanisms of accelerated aging phenotype and PTSD. So please welcome Dr. Bret Rutherford.
Well, thanks very much for that introduction, Jeff. I think it was perfect to set the stage for my talk today. I really appreciate everyone being here. Feel free to filter on down if it would be more comfortable. And it's really great to get a chance to present my work to all my friends and colleagues here and my home department. My talk today has 3 main parts. I'm going to start kind of big and tell you about our conceptual model and the approach we're taking in my division to develop precision interventions for late life depression. Then I'm going to show you a series of studies by myself and other investigators in my division that hopefully will illustrate how we're following this roadmap to develop these interventions. And then probably the last third or so of my talk, I'm going to really dive into the weeds on one particular study and show you some data on a treatment we believe has promise for treating late life depression. I don't have any disclosures today. We'll be talking in the last part of my talk about the off-label use of levodopa or Sinemet for depression. So precision medicine is the idea that we should tailor our therapeutics to the specific disease process and individual characteristics of a patient. Precision approaches, as you all probably know, have revolutionized treatment in many areas of medicine, most notably in oncology. One of the paradigmatic examples is in chronic myelogenous leukemia, where the standard of care in the 1960s and 70s was to systemically apply cytotoxic chemotherapy, which basically killed all rapidly dividing cells and temporarily lowered tumor burden, but had lots of toxicity and poor, was characterized by a lot of recurrence and poor 5-year survival. When it was discovered that a specific mutation caused many cases of CML, a specific treatment could be devised that inhibited the mutant gene product while leaving healthy cells intact. This worked better, was much more tolerable. So the situation will likely be pretty different in psychiatry, where we're dealing with complex genetic disorders and there's not one gene that causes late life depression. But the idea is the same, and the principles of the approach are the same, that we want to define etiologically homogeneous diagnostic categories and use that knowledge to target novel interventions to therapeutically tractable subgroups, and that we're going to use that knowledge of pathophysiology to rationally design interventions. Beyond genetics, we're going to be doing this using a whole lot of other information from neurobiology and cognition and family history, and critically, I would say, if you can see down here, developmental processes, and for late life disorders in particular, aging. That's kind of the main point of my talk, that aging is going to be a very valuable tool to understand the heterogeneity of a disorder like late life disorder, what causes it, and rationally design novel treatments. As Jeff said, we have area brain aging and mental health, which is one of our 12 research areas here. And just to put in a plug that for our division, the Neurobiology and Therapeutics of Aging division, using geroscience to understand heterogeneous late life illnesses, like late life depression is our whole reason for existing and what we do. I hope if nothing else, you'll get an idea in today's talk of the type of aging research going on here at Columbia, and anybody interested in adding a developmental or aging piece to their work, we would love to speak with you because we love collaborating. So maybe I can just spend a few slides trying to convince you of why we might need precision interventions for late life depression. For one thing, it's very common. Although big epidemiologic studies like the National Comorbidity Survey generally show that the prevalence of major depressive disorder declines over the lifespan, these numbers can be misleading for a couple of reasons. One is that the diagnostic criteria for major depression aren't age-adjusted. And as I'll go on to tell you later on, late life depression looks different from depression in younger adults. So by applying the same diagnostic criteria to everyone, irrespective of age, you end up underdiagnosing major depression in older adults. Secondly, there's lots of sub-threshold clinical symptoms in older adults that have big implications. If you look at symptoms, just as opposed to categorical diagnoses of major depression, 25% of community-dwelling older adults have clinically significant depressive symptoms. And rather than declining over the lifespan, when you look at symptoms, they tend to decline until the 5th or 6th decade of life and then start going back up. Apart from being common, late life depression is disabling and can be lethal. Just like in younger adults, depression in older adults is one of the main sources of disability, but there's additional toxicity to depression in later life. For example, late life depression is one of the foremost modifiable risk factors for dementia. As Dr. Lieberman mentioned, we're a part of an ongoing project to understand the brain mechanisms by which depression hastens the progress of dementia. We believe we're embarking on a longitudinal neuroimaging project in which we're examining two mechanisms by which depression kind of moderates dementia progression. One, by increased HPA axis activation leading to hippocampal toxicity, additional episodic memory impairment, and the other that inflammation and cerebrovascular disease associated with late life depression, causing frontostriatal lesions that disrupt cognitive control networks, lead to executive dysfunction. Apart from this disability and toxicity of late life depression, it can be lethal. I think most of us know that the people who actually kill themselves most often are older adults. Older white men in particular use more lethal means, they more often succeed, they give less notice, they have the highest suicide rates of any demographic group. So this combination of disability and lethality make late life depression one of our most pressing public health issues to address in older adults. Thirdly, I would argue that we need precision interventions for late life depression because our currently available treatments don't work very well. Antidepressant treatment in particular works less well acutely, and treatment is associated with a lot of chronicity and recurrence in older adults compared to younger patients. This is true if you look at our clinic. Here I just kind of summarized data from the last 362 people we treated in our clinic, and you can see that both response and remission rates to acute antidepressant trials are lower in older adults, here in white, compared to younger adults. We see basically the same thing if you look at the literature overall. Some of our meta-analyses of antidepressant response in younger and older adults, you can see response and remission rates drop precipitously. And this is also true in the largest, best-designed randomized controlled trials, where in late life, we often fail to distinguish drug and placebo. This is a study of Stephen Roos's in patients older than 75 treated with citalopram or placebo, and they didn't differentiate significantly. Now, one caveat to that is that it's hard to fully evaluate the evidence base for antidepressants in late life because there's simply so few studies available. We're part of a collaboration aiming to remedy this gap in the literature by collaborating with the 5 leading departments of geriatric psychiatry in the US and Canada to undertake the largest study of treatment-resistant late-life depression ever done. In this study, which is called Optimum, or Optimizing Depression Treatment in Older Adults, we're recruiting 1,500 patients aged 60 and older with major depression who have failed at least 2 antidepressant trials. Patients enrolling in this study either stay on their antidepressant and have it augmented with aripiprazole, or have augmentation with bupropion, or get rid of their antidepressant, get switched to bupropion. We follow people for a year if they respond to one of those treatments. If they don't respond, they enter step 2, where they're either augmented with lithium or switched to nortriptyline. So we should have data from this study available in the next few years, and it should provide some much-needed guidance about what to do for treatment-resistant patients given our current therapeutic armamentarium. So perhaps you can see in what I've presented so far that this current standard of care with respect to the treatment of late-life depression is disturbingly reminiscent of 1960s era cytotoxic chemotherapy. We pretty much indiscriminately apply nonspecific treatments, namely antidepressants, and we don't do a very good job of getting people better. So the question is, how can we improve this situation? And our intuition has been that we could do better by really taking seriously the idea that we're dealing with late-life depression, not regular depression occurring in an older adult. After all, late-life depression is different. It looks different from depression in younger adults. It is less often associated with low mood or sadness. It's much more often associated with cognitive and somatic complaints. Up to 50% of late-life depression cases have their onset after age 50. There's often a difference in a lack of family history of depression in these patients, and even the gender ratio between men and women evens out in late-life depression. Now, it may seem obvious in retrospect that depression in older adults has to do with aging, but that wasn't always the case. It was kind of the wisdom really up until the early 90s that basically depression in older adults was the same thing as depression in younger adults. When you treated it, you just needed to take account of various pharmacokinetic and pharmacodynamic differences. Start low and go slow with antidepressant medications, but the illness itself is not generically different from depression in younger patients. So let me tell you a little bit about what makes us think late-life depression is a disease of unhealthy aging. Well, for one thing, we've shown in large samples of older adults that measures of biological age are associated with depression both cross-sectionally, and they predict incident depression over time. These are data from the Health ABC study, which followed 3,000 community-dwelling functional older adults for 10 years. And we use these data to compute a multi-biomarker index of biological age. And one, I think, very striking thing we immediately saw is that similarly chronologically aged people, here everyone's 70 to 79 because that's who was enrolled in the study, but the same aged people have widely varying biological ages. You can be 70 years old chronologically and have a biological age of 50 or 110 in these data. And this is important because what we saw was that baseline biological age was associated with the severity of depressive symptoms you had at baseline. More importantly, baseline biological age predicted whether you developed clinically significant depression over the 10-year follow-up period of the study. Chronological age dropped out of the model once we included biological age, and we also accounted for numerous other covariates. One problem with what I've said so far is its non-specificity. So you might be a little worried about my career prospects sitting there if you've seen in the literature that basically aging has now been associated with every psychiatric disorder known to man. A quick Google search, you can come up with every psychiatric disorder has been called the disease of aging. And that, of course, that seems unlikely to be the case. Most of these studies report more advanced global indices of biological age in some patient group or another compared to healthy controls. And obviously, global indices don't get us any closer to therapeutically actionable specific processes than we were before. What we want, and what our focus in my division has been, is to go after and try to specify what I call late-life depression gerotypes. And a gerotype, as I define it, is a specific pattern of dysfunctional, age-related change in normative brain and other physiologic processes that increase risk for late-life depression, often has a characteristic phenotype. So to illustrate what I mean, before moving on, The first and really only gerotype established for late life depression before we began our work was vascular depression. And vascular depression, of course, focuses on a specific aging process, namely cerebrovascular aging, and according to which we all kind of experience change in our cerebrovasculature over time, more inflammation, blood pressure generally trends up with age, the blood vessel wall characteristics change. But while all of us experience cerebrovascular aging to some degree, some of us experience it more than others. And those kind of unhealthy cerebrovascular agers are subject to increased risk for developing vascular lesions, like these on T2 MRI, that interrupt important white matter tracts underlying and disrupt connectivity in brain circuits underlying cognitive control and executive function. So this process gives rise to depression with executive dysfunction. So I would say that the value of the vascular depression gerotype is it allows us to identify a specific subgroup of late life depressed patients and target them with primary and secondary prevention efforts to control cardiovascular risk factors and limit progression of white matter hyperintensities, and then try to treat the executive dysfunction once the overt disease becomes apparent. But another main point, I think, of my talk is that vascular depression doesn't exhaust the possibilities for how unhealthy aging can lead to late life depression. There's other aging processes that we need to look at as well. One reason we think this, as we've begun to look at evaluation data from our clinic, is that there seems to be a biologically interesting component structure to the data we collect on our late life depressed patients. For example, measures of speed and executive function, so processing speed and executive function seem to load on a kind of slowing factor. Measures of fatigability and physical performance and gait, medical variables like medical comorbidities and weight seem to load on a frailty factor. And global indices of cognition and memory kind of load on a memory factor. So we're going on to see in our patients to what degree late life depressed patients and healthy controls differ on these, on their factor loadings, and most importantly, to what extent late life depression patients kind of assort themselves into these groups on the basis of shared pathology. The implication would then be that we want to kind of potentially target these subgroups of late life depressed patients differently. Now, in order to do that and really attempt to identify what I've called these gerotypes of late life depression, we've really had to change the way we conduct evaluations in our clinic. And I think this is important point for the clinicians in the audience, that what constitutes a comprehensive evaluation for late life depression has dramatically changed over the last 20 years. In 1998, 20 years ago, when we did our studies, we performed, at the time, very comprehensive examinations, of course, documenting psychiatric symptoms and diagnoses, doing MRI scanning to quantify the regional extent and overall volume of white matter lesions, and of course, a very careful kind of neurocognitive assessment of executive function and episodic memory and other things. But when I reviewed what we do in our clinic just 20 years later, it's massively expanded. Of course, we still do careful clinical characterization of our patients. Neurocognitive assessment remains critical. Our palette of MRI modalities has increased to include task-based imaging, connectivity, and diffusion-weighted imaging. But we're also interested in all kinds of other things related to aging. Sleep quality in the presence of sleep apnea. Sensation, particularly hearing, strength, and things related to fatigue and frailty. Of course, indices of aging like telomere length and oxidative stress. Energy supply to skeletal muscle, so spectroscopy to look at ATP synthesis and skeletal muscle. And of course, really paying a lot of attention to function in our patients and looking at their gait speed and their ability, the short physical performance battery. If you look closely here, this is Patrick Brown all rigged up to something that I'll show you later. So, yes, he's got a mask on there that allows VO2 max calculation. So just to be clear, so that was kind of the first part of my talk, where I wanted to just show you our approach. We're trying to identify gerotypes of late life depression that'll give us the knowledge we need to design novel treatments and then target them to the patients having those abnormalities. I'd like to illustrate showing how I and other investigators in my division are kind of pursuing these different, what we see as really kind of different pathophysiologic roads leading to late life depression. We continue to do work on the vascular depression gerotype. We've started to look at the links between sensation change and neuropsychiatric disorders, and this will be Patrick Brown's work on frailty as a road to late life depression. I'll go through some of these, and then this is going to be the last part of the talk. I like this painting by Van Gogh, which he painted about 2 months before his death. It was called Sorrowing Old Man, from a pencil drawing titled Worn Out. And I think that's our model of unhealthy age, and really a kind of stigmatized version of aging as representing only kind of decline and wearing out. And this is kind of what we want to help with, obviously. I've maintained a big interest in the vascular depression gerotype, both due to the history of its, the important kind of work that's been done on vascular depression here at Columbia, but also because as successful as the vascular depression hypothesis has been in explaining how cardiovascular risk factors lead to increased risk for vascular lesions that interrupt these frontostriatal white matter tracts leading to depression and executive dysfunction. It's the hypothesis, very successful in that description and prediction of how baseline characteristics will affect treatment response. But it's been much less successful in giving rise to new treatments that are going to treat patients better. You know, aside from telling us that we need to aggressively treat cardiovascular risk factors, for example, there's really been few other suggestions. And as I came into the field, I wondered whether that might be because the hypothesis doesn't really explain why these frontostriatal lesions, for example, should confer antidepressant non-response. Vascular depression is often referred to as a frontal subcortical disconnection syndrome. And my question was, you know, what's being disconnected in this disconnection syndrome that should confer antidepressant resistance? The last time I was here, standing up here actually, I was telling you about my work on the mechanisms of placebo effects in antidepressant trials, and I presented data from a study in which I manipulated participants' expectations of improvement in an antidepressant clinical trial and determined whether expectancy predicted outcome. And what we saw in that study is that patients in the high expectancy group who received medication did much better. They experienced a lot more change in their depressive symptoms than patients who were in the low expectancy medication treatment group, and that clinical difference was mediated by the expectancy improvement in the high expectancy group. Now, the relevance here is that when we looked at the data, the study enrolled people from 24 to 75 years old. And when we looked at the data, it was clear that patients over 55 or so had very little, they were much less responsive to our expectancy manipulation than younger patients. So their expectancy wasn't as affected when we randomized them to the high expectancy arm or low expectancy arm. And expectancy had much less of an impact on depression. We knew from the MRI component of this study that many of these patients had white matter lesions on their scans. So I kind of got the idea that maybe rather than the medications not working for vascular depression, maybe what was being disconnected was the top-down emotion regulation pathway underlying expectancy-based placebo effects. So in other words, when we treated patients with late-life depression, what we were seeing is the medication component of response without the placebo component. So my first RL1 project was designed to assess that possibility, where we're enrolling a large sample of 130 late-life depressed older adults and characterizing them very comprehensively on measures of executive functioning, white matter burden, integrity of frontal striatal white matter tracts. And we're looking to see whether the link between executive function and white matter disease with antidepressant outcome, we know these things worsen antidepressant outcome, whether that relationship is mediated by a loss of expectancy-based placebo effects. If that were the case, it would really give us more information about, how we can try to get these patients better, namely by operationalized interventions to restore proper expectancies and really go after the executive dysfunction. So that's one ongoing road to late life depression, continuing to explicate the vascular depression story. Now, what about sensation change? We all see and hear and smell less well over time. And that actually, if we got interested in hearing, given that it's such an epidemic both in the US and worldwide, right? That 50% of people between 60 and 70 have clinically significant hearing loss when it's evaluated. Over 85% of people over 85 have significant hearing loss. Yet only 25% of people who could benefit from them use hearing aids. This is not just a quality of life problem, since hearing loss has been shown to be a major risk factor for dementia, both cognitive decline and conversion to dementia. We were intrigued by these links between hearing loss and dementia, and we were interested whether there might be a link between hearing loss and incident depression. Katie Brewster, one of our third-year psychiatry residents, took a look at this in this Health ABC data set we've been working with and showed that indeed, again, functional community-dwelling older adults with significant hearing loss were up 1.6 times the odds of this increasing risk for depression category and twice the odds of being on this high and consistently high depressive symptom category versus the low trajectory. We've gotten interested in exploring this further and really looking at the mechanisms linking hearing loss to late life depression. And reviewing the literature, obviously behavioral mechanisms, social isolation and decreased activities likely play a role, but there seems to be, as we review the literature, potentially interesting neurobiology behind this as well. That decreased auditory input seems to lead to compensatory recruitment of cognitive control networks that supports patients' efforts to discriminate speech in noisy environments. And this soaks up cognitive resources and decreases cognitive reserve, seems to lead to executive dysfunction, which is a risk factor for cognitive decline as well as depression. It also seems over time that the chronic deafferentiation of these auditory areas leads to atrophy, which has all downstream effects that kind of exacerbate the problem. Given this information, we were interested to take a closer look at this, and we embarked upon a study to study the obvious precision intervention for late life depressed patients with hearing loss, namely fix the hearing and give them hearing aids. So we began collaborating with colleagues in ENT, and we received some Columbia funding as well as a very generous donation of hearing aids, state-of-the-art hearing aids from Phonak, to specifically select a group of late-life depressed patients who had the type of hearing loss we expect to be linked to depression, namely kind of mid-frequency hearing loss associated with impaired speech discrimination. And we put them through a study where we carefully assess their hearing characteristics using audiometry with our colleagues. Of course, we assess their psychiatric symptoms. We put them through a neuropsychological assessment. We have NIA funding that will hopefully be coming through that will allow us to add a neuroimaging component to this. And we randomize these patients to provision of a fully functional and fully tuned hearing aid plus antidepressant treatment, or a little bit turned up hearing aid that helps you hear a little bit better, but not enough to discriminate speech that we think will be the key to getting undepressed, and antidepressant treatment. And then we follow these patients over 12 weeks to see whether provision of functional hearing aids as opposed to the sham condition gets people better in terms of the depression is associated with improvement in cognition. And when we're able to add the neuroimaging, we expect that we'll see improved activation and connectivity in the cognitive control network. As a third road to late life depression under study in our division, I'd like to tell you a little bit about the work of Patrick Brown, who's got, I think, a really exciting and original line of research on how increasing fatigue and fatigability in older adults leads to the medical syndrome of frailty and increased risk for depression. He calls this gerotype the frail depressed gerotype. When Patrick began with us, he noticed, I think very appropriately, that the frailty criteria defined by Linda Fried here at Columbia, namely 5 criteria defining this medical syndrome of frailty of decreased strength, becoming slowed down, shrinkage or weight loss, exhaustion, and decreased activity levels, but there's a big overlap between many of these symptoms and depression. And the question was, is this a result of diagnostic imprecision, or is there some interesting relationship between frailty and depression? Patrick did a bunch of analyses and they were all pretty consistent, showing that in fact, depression and frailty were each independent disorders conferring increased risk for the development of the other. In other words, here I have slow gait, which is a kind of core characteristic of frailty. If you're depressed, you have an increased risk of developing frailty. If you have frailty characteristics, you have an increased risk of developing depression. And as Patrick went on to take a look at the consequences of that, those risk increases, that it turned out that adding frailty to depression is a very bad thing. If you look as compared to depression without frailty, once you add frailty to depression, you double mortality rates in these data from the NORA study. In addition, frailty makes depression much harder to treat. This is an 8-week study from Patrick's K Award, where he treated patients who had, these are patients who have high fatigue levels, medium fatigue levels, or low fatigue levels. People with less fatigue do a lot better when we treat them with antidepressant medication. Intrigued by these results, I think Patrick very appropriately has gone on to look at the kind of behavioral abnormalities present in depressed patients with frailty. He's gotten interested in the biology underlying those behavioral abnormalities and has been using that knowledge of that biology to predict who's going to get depressed and not. So, and these are unpublished as yet, but he's gotten NIH funding to look at this stuff. It turns out in the data we've analyzed so far, depressed patients have altered EMG characteristics and gait kinematics compared to healthy controls. Their muscles, this is a long-winded way of saying their muscles fatigue more and faster than patients who don't have depression. And I think this is very interesting here. This is a measure on the kinematic data of toe clearance. So how far your right big toe, I think it is, gets off the ground. And you can see that depressed patients have much less toe clearance compared to same-age patients who aren't depressed. I think this begins to tell you how frailty doubles the mortality rate in late life depression, right? Falls, maybe. We know that toe clearance is linked to falls, and falls are a major source of morbidity and mortality in older adults. So what could account for the increasing fatigue of skeletal muscles and altered gait in these patients? Well, Patrick's gone on to look at, using spectroscopy, whether there's a decreased energy supply in skeletal muscle, so decreased ATP synthesis, leading to increased fatigue in the muscle. So here's a spectroscopy series. You can see the phosphocreatine peak here, and basically Patrick has people, sorry this didn't come out very well, but patients lie here and exercise their thigh muscles in the MRI scanner, and you can see kind of going into the screen is that time, and you can see how the ATP component of their muscles decreases as they exercise and then comes back up with rest. And so he's been looking at how this phosphocreatine recovery curve differs between depressed patients and controls, and how that the characteristics of that recovery curve predict in people who aren't depressed whether they're going to get depressed. And it turns out in this preliminary data that it does. People who if you look at longitudinal data from the Baltimore Longitudinal Study of Aging, as the ATP recovery of people's muscles decreases over the course of follow-up, they're subject to increasing risk of getting depressed. So the idea here is, now that we've kind of zoomed in on this biological abnormality that we think underlies fatigue and frailty and is important in this frail depressed group, we can target them with treatments, which now are mainly exercise, but that we hope as we kind of generate mitochondrial therapies of the future, we'll have additional treatments to offer them as well. So that was kind of a whirlwind tour. I hope I was able to make sense of that. I just wanted to illustrate how we've kind of given our conceptual model. We've launched a number of studies that we think represent distinct pathways to get depressed. And now I'd like to go into a bit more detail and show you some data from one of my projects, looking at how dopaminergic decline over the lifespan leads to psychomotor slowing and depression. So as I'm becoming increasingly aware, we all slow down as we get older. Here, and in particular, the speed with which we process information declines with age. I could show 1 million studies testifying to this, but here for fun, I'm showing you actual data on patients from our clinic, where you can see processing speed, as measured by the digit symbol substitution test, decreases with increasing age. Slowed processing speed is important all on its own, even apart from its link to depression. It's associated with poorer performance across almost every other cognitive domain, and it predicts risk for dementia. Slowed processing speed across healthy controls and numerous patient samples is linked to how many deficits in your functioning you have and the severity of those deficits. Similarly, as we've become increasingly aware, not just our thinking speed, but our physical movements slow down with age. Again, many studies showing this. These are data from our clinic. Patients' gait speed, when you just mark off typically a 15-meter course, and you ask patients to walk at their usual walking speed, their mean walking speed decreases with increasing age. Gait speed is an incredibly important health indicator. It predicts risk for falls, loss of the ability to live independently, and death. These are representative data, again, from the NORA study, showing a 27, if you have slow gait, here was defined as being in the bottom quartile of the sample. If slow gait as opposed to non-slow gait, you increase your mortality risk over follow-up by 27% if you're a man, and by 14% if you're a woman. So data such as these are why gait speed's been called the fifth vital sign, right? And it's now measured in medicine and hopefully increasingly in psychiatry as just as important as heart rate and blood pressure as a leading health indicator.
How do you measure gait? Do you tell people to walk as fast as they can, or just normal?
Normal gait. You mark off a course, you give them some time to ramp up and some time to slow down, and you kind of measure that once they get up to speed, and you tell them to walk at your usual walking speed. As I'll show you, sometimes we can, that's just gait speed, right? Then we can put them on a treadmill and look at all kinds of fancy stuff, from how fast their leg swings and how the force with which they push off, and how long their feet are on the ground in the stance phase. But just keeping it simple as the normal walking speed is a very powerful.
The reason I'm asking is because if you are talking about it as a vital sign, so temperature, heart rate, and resting heart rate, blood pressure, etc. So here you define it as normal gait, but yet normal is kind of subjectively determined.
Yeah. Jeff was asking about the kind of, well, you have a mic there.
Hello. Yeah, what I was saying is that if you're going to actually seriously consider gait to be a vital sign comparable to temperature, pulse rate, heart rate, respiration, those things are taken, they have physiologically kind of defined parameters, and they're taken usually at a resting state. Gait is something which is a subjective interpretation. So if you tell somebody walk at your normal speed, they'll walk at their normal speed, presumably. But they might not.
True. I think that's why ideally we put people on the treadmill and we look at and we can also stress them, right? How their gait characteristics change as they exert themselves is kind of where the money is in most cases. In this case, I'm just talking about a quick and dirty measure that even so does have a tremendous kind of predictive significance in the epi studies. But I get your point totally that obviously for our purposes in science, we want to do a much finer grained, more rigorous way of looking at it. But even so, it's worth.
The question, how do you sort of standardize mobility, which is, define it, but anyway, I don't want to belabor.
And well, yeah, maybe we can. There's more to say on that. The short physical performance battery includes normal gait speed as well as other parameters that tries to do that, but we can go into more detail with that. Processing, we all slow down processing speed-wise. We all slow down gait speed-wise. Both of those, even forgetting about depression, are bad. Both are very linked to depression, it turns out. Slowed processing speed is a crucial factor in late-life depression, what Yvette Chalene in 2006 called its core cognitive deficit. We see in many studies, this one by Patrick, that the effect of the disability associated with depressive symptoms is partially mediated through slowed processing speed. We see that when we treat people, slowed processing speed is one of the main negative prognostic indicators for antidepressant response. So people with slowed processing speed improve less in antidepressant clinical trials than people without slowed processing speed. And I think interestingly, even when we manage to get people better with our antidepressant treatments and we're talking about their depression, their processing speed doesn't improve. If you're slowed, you stay slowed even after your depression gets better. That means you're still subject to all the risks and bad stuff I just got done telling you about if you don't specifically go after the processing speed. Similarly, I've been arguing that gait speed's just as important in depression. I showed you our analyses showing that slowed gait is an independent, predicts development of depression over the course of follow-up. Both slowed gait and depression on their own are important predictors of mortality in older adults, but together they're even more deadly. This is one of my favorite figures from one of Patrick's papers. It looks at mortality rate as a function of depression, the magnitude of gait impairment, and inflammatory status. And you can see in these data, again from the Health ABC study, these were functional, independent patients at baseline who were followed over 10 years in their 70s. You can see that if you're not depressed, increasing gait impairment, so that in this direction here, the dark is the slowest gait and the worst gait, and it goes up like that. Increasing gait impairment has little effect. There's not much of a dose-response curve for gait if you're not depressed. If you are depressed, and then you add gait impairment to that, you do absolutely terribly. You're subject to massive mortality rates, which in this case, you're almost certain to die over the follow-up period. Here, your mortality rate's about 85%, which is nearly double the mortality rate in the low risk, low depression, low inflammation, low gait speed category. So it's data like this that has caused us to really zoom in on these patients and realize that we need to do something to treat them better or else they'll have incredibly dire outcomes. Just one more bit of background before I get to our study, that just as processing speed declines across the lifespan, gait speed declines across the lifespan, many indices of dopaminergic functioning decrease with increasing age. It's what's been called age-associated striatal dopaminergic denervation by Nick Bonin's lab, at least at Michigan. And this is not Parkinson's disease. We don't believe that loss of dopaminergic functioning normatively is a pre-Parkinson's state. Nora Volkow, in some of her PET studies, was one of the first to point this out, that you can see decreased D2 receptor density in these kind of increasingly aged cohorts. And many investigators, I'm just putting one slide here, but have linked these various PET indices of dopaminergic integrity to psychomotor speed. So in this case, decreased striatal dopamine transporter availability was associated with decreasing gait speed. So we put this stuff together and basically thought that since both processing and gait speed as well as dopamine decline with age and deficits and all of these things are linked to depression, we proposed conducting a study where we tried to replete dopamine as a way of speeding people up and hopefully treating their depression. So we ended up picking L-DOPA, and I'll tell you about that as our candidate therapeutic agent after considering other means of increasing dopamine availability like dopamine receptor agonists and stimulants. Basically, our criteria were that we wanted to, in a treatment that would increase dopamine availability, that had a lot of data testifying to safety in older adults, and had some evidence even in animals of increasing psychomotor speed. And L-Dopa, among those three options, was the one who the best fit those criteria. L-Dopa actually has a mildly checkered history in psychiatry. In the 60s and 70s, L-Dopa was investigated as a therapeutic agent for depression, sometimes at shockingly high doses. So you can see that in this case series, they were using 3 to 7 grams of L-Dopa, which is a very hefty dose. And basically, one thing we were intrigued by in these findings was that in all these reports, you see a lot of comments on increase in activation, increased speed of speech, less frozen, increased activation, psychomotor activation. We see an increase of activity. That was kind of a common theme in all of these things. Effects on depression were mixed at best in these case series. And of course, you can guess why that probably was based on the talk I'm giving, right? In order to see a signal of effect for a specific treatment like L-Dopa, you need to target it to people who are dopamine depleted. Dispersing it widely across a very broad and heterogeneous patient sample, you're unlikely to be able to pick out any effects. So anyway, this is the history. We were intrigued by the speed stuff, not so deterred by the depression effects in those data. But so I applied for and received one of these R61, R33 grants in order to study L-Dopa monotherapy for late-life depression with slowing. If you're not familiar with this mechanism, it's a 2-phase grant intended to fund the development of novel, mechanistically focused treatments. So in the first phase, the idea of the R61 phase, which is 2 years, you test whether your novel therapeutic agent, in our case L-Dopa, engages a hypothesized target mechanism that you think is related to your disorder, in our case depression. So we're testing in our R61 phase whether L-Dopa increases striatal dopaminergic transmission and increases processing speed and gate speed. If you're successful in this R61 phase, which is measured by whether you meet or surpass very strict operationalized criteria, in our case that we want to show decreased binding potential of raclopride post our L-Dopa dose, and that we speed up either processing speed or gate. If you show those things satisfactorily, you move on to this confirmatory randomized controlled trial, which is a larger, more rigorously controlled study where you want to know if your putative treatment has an effect on depression and to what degree engagement of the target mediates improvement in your target disorder symptoms. So we're in the R61 phase right now, and I just want to show you how we're doing so far. The study is a 3-week open study of increasing doses of levodopa with pre- and post-treatment PET scans and MRI. We measure people's processing speed and gate speed multiple times pre-baseline in order to, we do see practice effects with these things, of course, but there's evidence that practice effects kind of asymptotically peter out after a certain point. So we test them a few times. Then we have our week 0 where we begin 150 milligrams of L-Dopa, increase if tolerated to 300 milligrams, increase if tolerated to 450, and we do the post-treatment. We're evaluating processing speed and gate speed at each week, more or less treating them independent. There seems to be, from the Parkinson's literature, little carryover of L-Dopa effects, so that we're using week 1 versus week 0 as our measure of 150, week 2 versus week 0 as our measure of 300, and so on. We're recruiting patients 60 and older with a depressive disorder, broadly defined, who have clinically significant symptoms. These aren't people who have to have major depressive disorder, though, and have slowed gait. We selected 1 meter per second. This is the threshold used in most epidemiologic studies that increases risk for mortality and bad outcomes that I was telling you about. Also, this is a functionally important threshold. This is what red lights are set to, actually. So if you have a gait speed of 1 meter per second, you can get across the street. Kind of as I had indicated, we're recruiting, these patients don't necessarily come in saying, I'm really blue and despairing and sad. These are actual chief complaints from our patients. They come in saying, I feel slowed down, I've got no energy, I can't physically get going. So you can see we've enrolled 33 people in the study so far. They have a mean age of 74, they're mildly depressed, they have pretty good 28 on the mini-mental status, about 60% women, 40% men. And you can see here I just take the mean of our sample and compare it to what you would expect the processing and gait speed should be in age-adjusted norms. And you can see we're successfully recruiting people with slowed gait. And we're not specifically selecting people on the basis of slowed processing speed, but our sample does have decreased processing speed compared to age-adjusted norms. Here's what we're seeing so far in the 23 patients available for analysis right now. This is processing speed as measured by digit symbol, and we're seeing significant increases in processing speed at each dose of L-DOPA so far, about 150, 300, and 450. This is another measure of processing speed, the Salthouse's pattern comparison test. We see the same thing, significantly increased speed with L-DOPA. Here I have the effect sizes we're seeing for each dose, and there isn't much of a dose response curve here, which will contrast with what I'll show you next, but you can see we're seeing effect sizes that are pretty much, that are on par or above what we hypothesize and what's necessary for us to progress to the R33 phase. These are the data for gait speed and L-DOPA, so we're speeding up people's gait at all dosage levels, and here we are seeing a kind of increase in the size of the effect with increasing doses of L-DOPA. This is a single task gait speed, which you just tell people to walk their normal walking speed. Here's a dual task where we add a cognitive component which kind of introduces a processing speed in a way into the task, but we see increased speed with L-DOPA across all these doses, and the effect sizes, we don't see much for 150. They increase to above our kind of progression criteria limits by 450. Depressive symptoms were in a particular focus in the R61 phase, because that, again, is focused on target engagement. But we do see decreases in both rater-evaluated and self-report depressive symptoms over the 3-week, remember, it's just a 3-week study. Very well-tolerated treatment, which is why we picked L-DOPA, right? Among people who really enter the clinical trial, 8% have dropped out, 6% dropout rate due to adverse effects. Nausea and insomnia are the main adverse effects that we see. We've had no dyskinesias or motor adverse effects. In terms of our PET target engagement, very early days here. I just am showing you more just for fun what we see so far in our raclopride scans of patients at the beginning of the study and after subacute L-DOPA dosing. We're interested in whether L-DOPA decreases raclopride binding in sensory motor subdivisions of the striatum, so caudate and putamen, and you can't tell anything based on 3 patients, of course, but what we're seeing so far in these guys is about what we expect. Just as a methodological side note that I found interesting, the one reason I have so few patients to show you is that we had a different methodology when we began the study. We kind of modeled the study after the Parkinson's literature where we were looking at raclopride binding pre and post a single test dose of L-DOPA. And it turned out that in the first 6 patients we looked at, we weren't seeing any decreased raclopride binding after just a single dose of L-DOPA. Once we moved to subacute dosing and kind of targeted the imaging to when we were seeing the behavioral effects, the increased speed, we've been seeing the larger raclopride displacement, showing a more dopamine synthesis and release occurring. Obviously, the most proximal next step is that we need to do a bigger, this was an open study, we need to do a bigger placebo-controlled trial of L-DOPA. This will be the R33 phase, where we're going to focus on the effects of L-DOPA on depressive symptoms, see whether it works as monotherapy for late-life depression. We'll replicate the target engagement using our kind of new methodology and look at whether the PET indices of increased dopamine release mediate our antidepressant effects. Down the road, we really want to do further mechanistic studies. Really, we recognize that we're kind of systemically administering L-DOPA, to the whole brain here, and we're interested in looking in a finer-grained way at exactly what we're doing when we do this. We are planning to apply for funding, for example, to look at, is slowing really the cause of late-life depression in these patients, or is it kind of an index of decreased dopaminergic function and some other dopamine-dependent process causes the late-life depression? We also want to know exactly how does slowing lead to late-life depression. So, what we're interested in exploring, just to give you a preview, is whether slowing alters decision-making in patients leading to late-life depression, whether slowing increases the effort required for purposeful behavior, and basically changes the value proposition for behavior. If no matter how much I enjoy going out to dinner or playing with the grandkids or accepting a party invitation, if slowing dramatically increases the effort, that might tilt me in favor of isolation and decreased physical activity. So, I'm going to wrap up. Hopefully I've shown you today, I've kind of argued today that we need to develop better treatments for late-life depression. And that how I suggest we do that, or what we're following as a means of doing that, is using geroscience to understand how all the different roads people took to become depressed in later life, and use that information to design new and better treatments. The old way of doing things, if you just do a SCID and a Hamilton rating scale for depression, everybody looks the same. You apply a nonspecific treatment, doesn't go very well. We're hoping that with our new aging-based evaluation, we'll be able to understand what made this person get depressed and this person, institute a specific treatment focused on their deficit, and hopefully have better outcomes. I'll just end with the words of one of my favorite poets, who, we want to get away from the Van Gogh's worn-out, sorrowing old man. Aging is more than just a picture of deterioration and decline. What we, as kind of stewards of the aging process in our patient, we want to help them achieve an old age serene and bright and lovely as a Lapland night shall lead thee to thy grave. So, thanks very much for your attention, and really thank you to everyone this is a group effort, everything I showed you. I want to particularly thank Stephen Roos, as Jeff mentioned, has now been the best mentor anyone could ask for the past 14 years, and everything I talked about today has been developed in discussion with Stephen, and really is as much his as it is mine. This is some people from our division in our late life depression clinic. We've got many wonderful collaborators, Melanie Wall, of course, and Adam Ciarleglio, helping with the design and analyses of these studies. Our Optimum collaborators, Anna Kim, an ENT surgeon, helping out with the hearing work. Adam Brickman and others from neurology, helping out with collaborating with us. Joel Sneed from Queens College, and Mark Slifstein and Anissa from Stony Brook, collaborating on the PET studies. So, thank you very much.
Bret, thanks very much. This is really a very rich and largely sort of uncharted area, and it really verges from treating neuropsychiatric conditions in the population to basically what's kind of normative aging, and almost sort of into what primary care might sort of address itself to. And for those of us who are aging, it seems more and more relevant. You may have said something, but I may have missed it, but are there reliable cellular markers? Because Freed's work with frailty and allostatic load from Bruce McEwen, as medical science progresses, as quality of life improves, so longevity over the past 2 centuries has continually increased, with the exception of the middle-aged rural demographic data more recently, and has every prospect of continuing to do so, because food supply is more abundant, the public health strategies, so forth are better. So people are going to be healthier, live longer. They can have reduced mortality from disease, and then it's going to be aging, which is going to do them in. And so the idea of being able to sort of optimize, your ability to age successfully and not succumb to the kind of deterioration that may be normative is going to be more and more of a target or sort of a limiting factor and something to try and sort of overcome. Are there any cellular markers of this that are reliable, a telomere length or cellular assays of oxidative stress, et cetera?
Yes, I believe I wouldn't say I'm a total expert in that stuff, but telomere length, DNA methylation, F2 isoprostanes as a measure of oxidative stress. I think these things have been pretty good biological clocks.
Are they being used at all?
Yeah.
I mean, clinically or just at a research level?
To my knowledge, at the research level and mainly in large data sets. So I think it's not necessarily cellular, it's something a little kind of lower tech, but actually interesting are these multi-biomarker indices. If you just take like standard assays of function in different tissue types and you aggregate them together, they've shown to be very powerful. The David Belsky's proceedings in the National Academy of Science paper a couple of years ago, where he showed that even at a young age, and from like your mid-20s to your mid-30s, you could use these biomarkers to predict the pace of aging, how old you look, in terms of your face, how your physical functioning, your cognitive functioning. So I think there's a number of markers, and including aggregating the results of things like hemoglobin A1C and creatinine and into a biomarker that we can use to look at aging.
You always see these before and after pictures of presidents, and shows how the effect of aging. And there's now all this discussion about President Trump and how the annual medical exam should be expanded to cover other things. But just apart from that, it would be interesting to apply this as well. You'd have your built-in natural experiment, because you talk about sort of a stressful 4 or 8 years.
Sure.
Just to switch to the other sort of end of the research spectrum. So this is, the demographic trend being what it is for more and more people, more and more older people as proportion of the population. The healthcare workforce is underpopulated in terms of people who are trained in geriatric healthcare positions. So, and this would expand it even further. I mean, you can see the whole neuropsychiatric area is able to really sort of expand itself and to be more involved in sort of promoting healthy aging and also addressing whatever pathologic conditions occur. So what are we doing about that? I mean, how are we going to get people to go into this discipline better?
That's a good. I mean, my first response to that is that I don't think the answer is to get more geriatric psychiatrists necessarily, because once somebody's 65 or 70, the horse is out of the barn in many cases. And I think what we want to do is push our attention to these aging processes back into the 20s and 30s and 40s and into all areas of medicine, so that what we want to do is identify people, and that's a lot of what we try to do, or where we're moving towards, is try to catch people when they fall off this normative healthy aging trajectory and they're getting onto an unhealthy aging trajectory. But before, they have all kinds of white matter lesions, or their hearing goes and they have atrophy of the auditory cortex, and institute some treatment then to get them back onto a healthy aging trajectory. So maybe it's not so much by kind of increasing the number of people we have treating 65 plus people, but by kind of diffusing this knowledge of aging processes into kind of all people treating 30-year-olds and 40-year-olds, and that's when we want to really intervene.
Well, I have a bunch more questions, but I'm not going to monopolize things. Let's start with Dev.
Very nice talk, Bret.
Thanks.
One thing coming across from your talk is that all these things are chronic, and you're pulling the data from epidemiological studies as well as the clinical work you've done with Patrick, Steve, clinic. But with depression, you have state and trait. You have some people you're seeing at certain points in time or in an episode, out of an episode, maybe major depression, maybe another type of depression which still fluctuates, and some partially treated. So I'm wondering if you can talk about the state versus trait issue, because a lot of your work is really related to depression and how that's impacting on your aging parameters like frailty and processing speed.
If I understand, I'm not sure this is your whole question in a way, but clearly the relationship between these aging processes and depression goes both ways, right? Not only does, and that's probably true of many psychiatric, to the extent that aging can increase risk for certain psychiatric pathology, having psychiatric disorders, we think, leaves a kind of biological scar that accelerates the aging process. So these things interact with each other. I'm not sure if you're also kind of getting at the thought that, we don't know exactly, we don't know exactly from the studies we've done so far, at what point fixing these aging processes is going to treat the depression, or whether they might have passed a point where, if your kind of hearing loss has, resulted in long-term kind of chronic atrophy of certain brain areas, giving you hearing aids at that point may not be sufficient to address the depression. So the issue of kind of when is the kind of point on the curve where you can fix the aging process and hopefully have a positive impact on the depression is also a question in our minds. But I'm not sure if I exactly answered what you were.
It partially addresses that. Maybe another way for me to ask the question is, some of these patients are chronic and will continue on the aging path, normative aging or declining. But many of them fluctuate and actually improve. And then your assessment that this is really part of the aging process maybe need to be modified because the depression is fluctuating and improving from time to time. That's
I see. Okay, well that, actually I don't need to get to it, but maybe one thing that you're saying, plenty of people get depressed in their 20s and 30s, right? For maybe other reasons, there's another pathology to early onset depression. Depression is a recurrent illness across the lifespan. So we'll see them get that depression coming back at 60 and 70 and 80. We could also have people who have some aging-related insult to their brains causing that they didn't get depressed in their 20s and 30s. They get depressed for the first time at 65 due to a vascular lesion or hearing or dopaminergic depletion. Just looking at people who are in their 60s and 70s, we don't know, without doing the kind of careful evaluation I've been talking about, who's having a recurrence of an early onset depression versus who's having a late onset depression with some identifiable pathology. And likely that kind of diversity in the cause of the depressions we're seeing might, we think that the kind of late onset brain injury depression is chronic and doesn't really come and go too much. It's likely that the kind of early onset non-vascular lesion, recurrence at age 70 might be more treatable and kind of go away. So we're seeing, maybe that's more of an answer to your question. We see some dense depressions that don't go away, and we think that's linked to brain pathology that we haven't been able to modify. Other times we may be looking at recurrence of earlier life depression that might be more treatable.
Yeah, I think maybe what Deb's getting at is that when you see depression in younger persons, it's incongruous with what the normative behavioral profile would be. When you see it in older individuals, it can be perceived as, occurring as part of the aging process. And that's also related to the whole pseudo-dementia issue, isn't it? Yeah. Steve, you were going to comment on that?
I think there's another way of that. I don't think depression is not part of the normative aging process. It's a way that younger people think about, well, you're slowed down, you're fatigued, you're getting old, and so forth. Most older people have very healthy trajectories, very active, can outrun all of us. I think in reference to what Deb is saying is that we think of depression as an episodic illness fluctuating. You got a depressive episode, then you're well. And as Bret was alluding to, in late life, there's a lot more chronicity. We're not talking about with many of these patients, are you depressed or not depressed, but just how severe the depression is at a particular point. And there's less fluctuation. We have less good treatments, and we're dealing with much more kind of, whether it's chronic state or ongoing trait, there's much less variation that we have than in younger people.
Yeah, just to add to that point, yeah, I think it's kind of a stigmatized view of aging to say that depression is a normal response to the aging process. That, in fact, normatively, most people get happier and more kind of, the so-called positivity effect of aging is kind of the normative pathway. And late life depression represents a real falling off of that healthy emotional aging pathway.
Yeah, no, this is, I mean, everything, you're absolutely right, as far as I know, and I wouldn't disagree with it. But the whole trajectory of medicine in general, and particularly psychiatry, has been to pull out and distinguish pathologic conditions from what had been, through basic ignorance and some stigma, kind of just absorbed into the normative variation of human behavior. I mean, aging is part of the process of aging is getting cognitively impaired and slow and looking like you're depressed. Autism wasn't identified in the literature until 1947, but it existed for millennia. So what were these people? These people were, either thought to be mentally slow or asocial or different or some. So, there's a part of the fabric of humanity and society until science kind of defines the phenomenologic characteristics and then ultimately, the pathophysiologic and ultimately etiologic sort of underpinnings. So I think, aging has been one of kind of the final frontier, or aging. Pediatrics has even advanced over aging, I think, in that respect. So, any rate, that's just an editorial comment. Melissa.
Hi, Bret. That was really wonderful, very clear and exciting work. I think it's a wonderful example of just the kind of amazing translational research that's happening here in terms of really thinking about using basic science to inform our understanding and treatment approaches to patients. I'm sure you get asked this all the time, but I was very intrigued by the link with the processing speed, and certainly there are numerous apps on the market that sell themselves as being able to help brain health and supposedly things like processing speed. And I'm wondering if that's actually, I've heard that that's not really legitimate, and I'm wondering what your opinion is.
Well, we have a couple experts here in the audience who can definitely speak to this. Joel Sneed there could. Joel, do you think this would be fair? That certainly, as I review grants, and it's not just in the popular culture. When people are looking at, particularly with vascular depression and addressing cognitive control abnormalities and trying to find a way, we can't fix the white matter lesions. How do we improve executive dysfunction and speed people back up? Cognitive remediation using video games and all kinds of stuff is a very frequently investigated thing now. Would it be correct to say that it's an open question whether, certainly we can train people to the task and you can speed them up and you become better at whatever game you're using to remediate their cognition, but it's a big question of the transferability of those effects and what they mean in terms of kind of ongoing kind of health and risk factors for bad outcomes. What would you say, Joel?
Absolutely. Yeah, it's exactly right. There's a whole issue about transfer of effects and everything that current research is looking at. I have a grant with Dev in looking at exactly this issue in older adults with cognitive impairment, and it's not clear.
Well, Joe, while you've got the microphone, what would you say about luminosity and Prevagen? No expletives.
Yeah, right. That's right. Yeah, we're working with them closely.
Oh, are you being facetious?
No. In our study, actually, lumosity is allowing us to use some of their procedures as part of the investigation. So it's not just that, but also doing fMRI in the study to see whether because we know there's some cognitive improvements when you start doing these video games and these tests. But what does it do to the brain? Does it transfer elsewhere? That is really being studied, and that's really what we're focusing on.
Yeah, but is it any different than playing bridge?
It is in one way.
It costs money.
The way to think about all these cognitive training games is really, it's like doing a neuropsych battery, but in a gaming platform and constantly doing it over and over again in different ways.
It's
So
like,
actually, most of these video games are developed from standard neuropsychological test paradigm. That's all we're doing.
Alex,
So what I got was you can age different ways, and basically specific functions will start to degrade. And if you target the specific functions, depression can improve, or depression response, antidepressant response can improve. So two questions, right? First is, how specific is this to depression? Do you think other psychiatric and maybe even medical conditions will improve if you target the specific degenerative processes associated with aging in an individual? And sort of going back to psychiatric issues is, the second question is, can we sort of think about it as a change of interpersonal health, right? Your relationship to yourself, and in that sense, would some treatment strategies that are targeting our response to our own internal change, for example.
Hold, I'm sorry. I've
Okay.
cognitively aged out of your first question already. I would say the first question, like, certainly and I guess my thought on that would be, precision medicine is the idea that we want to find out what caused your illness. We want to then target our treatments to something that's going to fix that in you who have that abnormality. Now, I presume illnesses vary in terms of to what extent aging is an important cause of whatever you're dealing with. If you have some, it so happens that late life depression, there's lots of reasons to think aging plays a critical role in the causation of late life depression, right? People who never got depressed before get depressed when they're 60, and it seems to be related to age-related bad stuff that happens in their brain with their functioning. So I guess in terms of aging per se, the extent to which your illness du jour is caused by aging processes would impact, how fixing aging processes or optimizing aging would affect the target disorder. Now, what is that? Well, if that was any kind of response to your first question, what was the second one again?
Yeah, no, that's great. The second one is, we conceptually, can we target just change in general, and how it relates to depression and our psychiatric health? I mean, one of the things that comes to mind is IPT, for example, that sort of targets your relationship to the status of where you are and how you're changing. Has anyone looked at it, or do you think IPT would work especially well in the geriatric population based on this?
Maybe, I'm sure Stephen could kind of speak to this, but the Pittsburgh folks and Ellen Frank and others have done, have shown good effects in studies of IPT and nortriptyline in older adults, with IPT monotherapy, I believe, having comparable effects to nortriptyline monotherapy. I think, a common, maybe what you're getting at in a way too, is that some of the kind of biological processes of aging have as their a kind of common endpoint isolation and reduced activity levels and decreased social interaction. That may be an important kind of psychosocial mediation of the aging biology and the depression, so that we could target the biology. We could also target the psychosocial sequelae of the biological abnormalities, and maybe IPT would be a productive way of doing that.
Is there any evidence
Yeah,
that it works better than in young people?
Yeah.
The studies about IPT and antidepressants, the studies about IPT and antidepressants done by Ellen Frank and Chip Reynolds and so forth in older people, look, it worked when they were given nortriptyline, and the sustained effect happened in combination with medication and medication alone. And I think that speaks to one of the things that Bret is talking about in terms of the potential biology. If you are slowed down and it takes too much effort to get up and see somebody, it'll distort your interpersonal relationships. But just focusing on the interpersonal relationships won't necessarily alter the underlying biology that leads to the disrupted interpersonal relationships. So I think much of what Bret's talking about is going back to earlier steps that certainly can lead to social isolation and consequence, but that you need to repair certain things in It's the same thing in studies that we did about with psychological mindedness and dynamic therapies in depressed patients. Treating the underlying depression made, in fact, people much more available and responsive in terms of psychological mindedness to dynamic therapies.
Yeah, I'd like to make.
Ralph.
Yeah, I'd like to make a comment, having seen 300-year-old people in the past year and having a relative who lived to be 100. And one vignette, but it deals with what you're saying about isolation. To what extent is isolation a result or isolation a cause? This 100-year-old relative of mine had a home health aide who had a baby. And when she brought the baby into the house, there's no question about the effect on this senior citizen who was 100. So the question is whether isolation is an important predictor. Are these people living alone? Have they lost a spouse? Have they had a move? And how much the social context affects aging. I think it'd be absurd not to include. I mean, I love the idea of molecular psychiatry, but I think aging has so many interfering situations. You've got to look at the social context and with whom the person is living, how many relatives have they lost, how many relatives they have to get to 100.
Yeah,
I think
isolation.
The social isolation.
It's isolation. It's also the stimulation that's.
Exactly.
You remind me of, I believe her name was Jeanne Calment, the oldest human known, right? She lived to be 121 or 122, and there was a famous story about how she had the best house in town, and the young whippersnapper lawyer, when he was in his 50s, came. He wanted to buy her house, and they worked out a deal where he said, "All right, I'll just pay you. I'll make basically monthly payments to you until you die, and then I'll get the house." And this was when she was in her 80s, and so she said, "Okay, great." So of course, they would have birthday parties for her every year, and he would attend. He ended up paying her way more than the house was worth. He died before she did, but she was a real character as far as I understand. She attributed her longevity to giving up her 2-pack-a-day smoking habit and chocolate at the age of 112. So maybe that helped her get to 121.
Well, we have to stop now, Bret, but I just wanted to take issue with one thing you said. I think we need to start early with the kind of incorporating either health practices or attention to conditions that could involve, people earlier in life. But, I think we still need a larger sort of geriatric neuropsych workforce, because not just for the current generation, because it's going to take a long time for that to actually happen.
Yes.
But anyway, this is introducing a new sort of dimension to what previously passed for geriatric psychiatry, and it's a real growth sector of the field. So thank you for telling us about it.
Thanks for having me.